Welcome to this session of TMA's Spotlight videos. Today we're going to provide you with an overview of the recently passed Medicare Access and CHIP Reauthorization Act of 2015, which repealed the Medicare Sustainable Growth Rate formula, also known as the SGR. We will briefly explain what the SGR was and why it needed to be replaced, and give you the details of the Medicare payment structure that replaced it. First of all, what was the SGR? It was a formula that was enacted by Congress as part of the Balanced Budget Act of 1997. The formula limited growth in spending for physician services by linking reimbursement updates to target rates of spending growth. In determining the target rate, the formula looked at projected growth in the real gross domestic product, or GDP. When Medicare spending exceeded the target rate of growth, payments were supposed to automatically reduce across the board. The SGR did not control the volume of care provided and actually cut payments without regard to the quality of care provided by an individual physician. Because of those auto reductions, every year since 2001, the SGR threatened to impose steep cuts in Medicare physician payments. As a result, each year, Congress would pass temporary legislation to avert these steep cuts. In fact, Congress has spent almost $170 billion over the last 12 years or so on these SGR patches, which is more than the cost of simply repealing the SGR. This cost is a large part of why this year Congress finally passed legislation to repeal the flawed SGR formula and replace it with something different. So, what does this legislation do? First, and probably most importantly, the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA for short, repealed the flawed SGR formula. By doing so, it also averted a 21% decrease in Medicare physician reimbursement that was set to go into effect in April. Second, the legislation sets up a new schedule of payment updates for the next 10 years that are not based on any formula. We will see a chart explaining those payment updates on the next slide. Finally, it ties those payment updates to some of the payment reform models that the federal government has already started. These include alternative payment models, such as ACOs and patient-centered medical homes, and value-based payments, such as PQRS measures and value-based modifiers. MACRA also builds on the current federal electronic health record meaningful use requirements. This chart represents the annual payment updates that are included in the new law. As you can see, starting in July of this year through 2019, there will be an across-the-board 0.5% increase in physician Medicare fee-for-service rates. From 2020 through 2025, that 0.5% payment update will go away. But physicians will then be eligible for bonuses under the Merit-Based Incentive Payment System, or MIPS for short, which I will discuss in more detail later on. Reimbursement under the MIPS program would still be fee-for-service. Physicians could be eligible for up to 4% bonuses or penalties in 2019, with those percentages increasing up to 9% from 2022 to 2025. Additional bonuses of up to 10% are possible for exceptional performance, with $500 million of Medicare funds set aside each year for that purpose. Physicians who receive a significant share of their revenues through an alternative payment model that involves risk of financial losses and a quality measurement component will receive a 5% bonus each year from 2019 through 2024. Patient-centered medical homes will be exempted from the downside financial risk requirement if proven to work in the Medicare population. Also, starting in 2026, those same physicians will receive a 0.75% payment update, while physicians not participating in an alternative payment model will only receive 0.25%. The merit-based incentive payment system will utilize some aspects of currently existing Medicare programs, including the Physician Quality Reporting System, or PQRS, the value-based payment modifier, and EHR meaningful use requirements. However, The idea behind MIPS is to make sure these programs are more flexible and fair. For starters, at the end of 2018, the PQRS 2% penalty, the value-based payment modifier penalties, and the 3% EHR meaningful use penalty will go away, and the MIPS program will begin. Before MACRA was passed, these programs' penalties would have exceeded 9% of Medicare reimbursement in 2019, so removing their impact is a positive for physicians. Starting in 2019, MIPS will be the only Medicare quality reporting program. We will discuss what is included in MIPS on the next slide. Under MIPS, physicians will know their performance thresholds for bonuses and penalties up front. Also, performance will be on a sliding scale based on what is relevant to the physician's practice, and not the all-or-nothing approach in PQRS and EHR meaningful use. Even if you partially meet performance metrics, you will receive some credit. If a physician participates in an alternative payment model like an ACO or patient-centered medical home, he or she is exempt from the MIPS program. Additionally, any physician with a low level of Medicare claims will be exempt, although the exact number of claims has not yet been set by CMS. Performance under MIPS will be measured based on 4 assessment categories: quality domains, resource use, meaningful use, and clinical practice improvement activities. Quality measures will be reported through certified EHR technology or qualified clinical data registries. The quality category, which is based on current PQRS measures, will be weighted at 30% of a physician's overall assessment, as will the resource use category, which is based on the value-based payment modifier program. The meaningful use category will consist of 25% of the assessment, and the clinical practice improvement activities will constitute 15%. It's important to note that the weights assigned to these performance categories may change over time. Each year, the Secretary of HHS will publish a list of quality measures to be used in the forthcoming MIPS performance period. All interested parties will have the opportunity to comment on the measures before they become final. Quality measures selected for inclusion on the final list will address all 5 of the quality domains listed on your screen: clinical care, safety, care coordination, patient and caregiver experience, and population health and prevention. Physicians will receive a composite score of 0 to 100 based on performance in each category, and will only be assessed for categories, measures, and activities that apply to them. To incentivize improved performance, physicians will receive credit for improving from year to year. Each eligible medical professional score will be compared to a performance threshold. Those whose composite scores are above the threshold will receive positive payment adjustments, and those with scores below the threshold will receive negative payment adjustments. Negative adjustments will be awarded proportionally and capped at 4% in 2019, 5% in 2020, 7% in 2021, and 9% in 2022. Positive adjustments will also be awarded proportionally, up to a maximum of 3 times the annual cap for negative payment adjustments. The good news is your payment adjustment in one year will have no impact on your payment adjustment in a future year. In addition to the payment adjustments and potential bonuses or penalties, MACRA includes provisions that are supposed to help providers increase the quality of care they provide. For starters, the use of telehealth and remote patient monitoring are included in the 4th MIPS assessment category, clinical practice improvement activities. And APMs may include reimbursement for telehealth services even if it's not covered by traditional Medicare. The law requires EHRs to be interoperable by 2018 and prevents providers and hospitals from blocking information sharing between EHR vendor products. The law includes some medical liability relief as well. A physician's participation or non-participation may not be used in a medical malpractice lawsuit, nor can the quality program standards be used as a standard of care in a lawsuit. Also included in MACRA is up to $20 million per year from 2016 to 2020 that will be appropriated to provide technical assistance to practices with 15 or fewer professionals to help improve performance in or transition to an APM or MIPS. Finally, physicians will receive confidential feedback on performance in the quality and resource use categories at least quarterly, which will likely be through a web-based portal. These reports should give providers the opportunity to adjust their practices throughout the year to better position themselves to receive performance bonuses. This video is just a brief explanation of the SGR repeal legislation. To find more information, please visit TMA's Medicare Physician Payment Reform webpage, which you can access on our website at www.tnmed.org. It includes an explanation of the SGR repeal legislation, new information as it becomes available, and links to AMA resources, which were used to create this spotlight video. TMA will also send any updates through our weekly e-newsletter, TMA Weekly, which contains important topics that each physician and practice member should review. If you are a member and do not currently receive TMA Weekly, please email the TMA Legal Department at legal@tnmed.org. If you have any questions about anything we have said in this webinar or about the SGR repeal legislation in general, please email the TMA Legal Department or call us at 1-800-659-1862. You can visit our website at www.tnmed.org for continuous updates on the legislation and any other laws or issues affecting the practice of medicine in Tennessee. We also have an extensive law guide with over 150 topics related to the practice of medicine, which you can find at the link printed at the bottom of your screen. This resource is for TMA members only, so you will need your member ID and password to access any of the law guide topics. If you are not a member and are interested in joining the TMA, please visit our website to learn more and begin the registration process. Thank you for listening to this session of TMA Spotlights.